Hello, this is Brandon. Today we're going to look at health assessment, Chapter 19, Thorax and Lungs, the Workbook edition. Like always, we're going to start off with some terms. It's been a long day. This chapter is very long. But here we go. Alveoli, functional units of the lung, the thin-walled chambers surrounded by networks of capillaries that are the site of respiratory exchange of carbon dioxide and oxygen. Got angle of Lewis, it's the manubriosternal angle articulation of the manubrium and bottom of the sternum, continues with the second rib. Apnea, cessation of breathing. Asthma, an abnormal respiratory condition associated with allergic hypersensitivity to certain inhaled allergens, characterized by inflammation, bronchospasm, wheezing, and dyspnea. Atelectasis, an abnormal respiratory condition characterized by collapsed, shrunken, deflated sections of alveoli. Bradypnea, slow breathing, fewer than 10 beats per minute. Bronchial, one of the smaller respiratory passageways into which the segmental bronchial divide. Bronchitis, inflammation of the bronchi with partial obstruction of bronchi due to excessive mucus secretion. Bronchophony, the spoken voice sound heard through the stethoscope, which sounds soft, muffled, and indistinct over normal lung tissue. Bronchovesicular, the normal breath sound heard over major bronchi, characterized by moderate pitch and an equal duration of inspiration and expiration. Chronic obstructive pulmonary disease, COPD, a functional category of abnormal respiratory conditions characterized by airflow obstruction. Cilia, millions of hair-like cells lining the tracheobronchial tree. Solidation, the solidification of portions of lung tissue as it fills up with infectious exudate as in pneumonia. Crackles, rails, abnormal, discontinuous, adventitious lung sounds heard on inspiration. Crepitus, coarse crackling sensation palpable over the skin when air abnormally escapes from the lung and enters the subcutaneous tissue. Dead space, passageway that transport air but not available for gaseous exchange, and the trachea and bronchi make up the dead space. Dyspnea, difficult labored breathing. Emphysema, chronic obstructive pulmonary disease characterized by enlargement of the alveoli, distal to terminal bronchi. Fissure, a narrow crack dividing the lobes of the lungs. Fremitus, a palpable vibration from the spoken voice felt over the chest wall. Friction rub, a coarse, grating, adventitious lung sound heard when the pleurae are inflamed. Hypercapnia, increased levels of carbon dioxide in the blood. Hyperventilation, increased rate and depth of breathing. Hypoxemia, decreased level of oxygen in the blood. Intercostal space between the ribs. Kussmaul respiration, type of hyperventilation that occurs with diabetic ketoacidosis. Orthopnea, ability to breathe easily only in an upright position. Proximal nocturnal dyspnea, suddenly awaking from sleep with shortness of breath. Percussion, striking over the chest wall with short, sharp blows of the fingers to determine the size and density of the underlying organ. Pleural effusion, abnormal fluid between the layers of the pleura. Raunchy, low-pitched, musical snoring, adventitious lung sounds caused by airflow obstruction from secretions. Tachypnea, rapid, shallow breathing, more than 24 breaths per minute. Vesicular refers to soft, low-pitched, normal breath sounds heard over peripheral lung fields. Wheeze, high-pitched, musical, squeaking, adventitious lung sound. Xiphoid process, sword-shaped lower tip of the sternum. Alright. Looking over the notes. Pleurae, thin, slippery membranes that form an envelope between the lungs and the chest wall. Visceral pleurae lines the outside of the lungs, dipping down into the fissures. Parietal pleurae lines the inside of the chest wall and diaphragm and is continuous with the visceral pleurae. Structures that compose the respiratory desperation, trachea and bronchi make it up. Inspection of the posterior chest, look at shape and configuration of the chest wall. Symmetry of the thorax, anterior posterior diameter, neck and trapezius muscles, position person takes to breathe, skin color and condition. Inspection of the anterior chest, we look at the shape and configuration of the chest wall, costal angle, note facial expression, assess level of consciousness, assess quality of respiration, symmetry of chest expansion, assess for retraction or bulging in intercostal spaces, assess for use of accessory neck muscles for respiration, assess respiratory rate. I know what burial chest is, pretty easy. Discontinuous sounds, fine, coarse crackles, telepathic crackles like a profection rub. Continuous sounds like a wheeze, high pitched, low pitched, strider. Normal costal angle is 90 degrees or less. 90 degrees or more, I'm sorry. Less, my bad. Crazy. So the anterior posterior diameter compared to transverse diameter should be 1 to 2 or 5 to 7. And if it's equal, it's barrel chest. Tripod position is when the person leans forward with arms braced against the knees. The chair or the bed gives the person leverage so that the rectus abdominis and the consoles. So they lean forward, arms braced against the knees. Okay, relative factors that affect tactile firmness, relative location of the bronchi, chest wall, thickness, chest wall, pitch, and intensity. Resonance is a predominant sound in healthy lung tissue. And there are 5 factors that affect osculation are as follows. I had 4. Examiners bumping on stethoscope tubing bumping together, patient shivering, patient's hairy chest, and rustling of paper gowns and drapes. Now I have some questions for you. What's the manubriosternal angle? The articulation of the manubrium and body of the sternum. Give me a good description of the left lung. Just said narrower than the right lung with 2 lungs. So you assess the patient who reports a cough. The characteristic timing of the cough of chronic bronchitis is what? Productive cough for at least 3 months of the year for 2 consecutive years. So the following assessments best confirm symmetric chest expansion. Place your hands on the posterolateral chest wall with thumbs at the level of T9 or T10. Then slide the hands up to pinch a small fold of skin between the thumbs. You're oscillating breath sounds on a patient, which the following best describes how to proceed. Hold the diaphragm with the stethoscope against the chest wall. Listen to 1 full respiration in each location, being sure to do side-to-side comparisons. What's the best description of bronchovesicular breath sounds? Moderate pitched, inspiration equal to expiration. After examining a patient, fever, increased respiratory rate, chest expansion decreased on the left side, dull to percussion over left lower lobe. Breath sounds louder with fine crackles over left lower lobe. These findings are consistent with lobar pneumonia. On examining a patient's nails, you note that the angle of the nail base is greater than 160 degrees and that the nail base feels spongy on palpation. These findings are consistent with congenital heart failure and COPD. On osculating a patient, you note a coarse, low-pitched sound during inspiration and expiration. This patient reports pain with breathing. These findings are consistent with pleural friction rub. What's the technique for agophony? Saying E each time the stethoscope is moved. When examining for tactile firmness, it is important to ask. Important to do what? Palpate the chest symmetrically. Buzz pulse oximetry measure, arterial oxygen saturation and hemoglobin. A pleural friction rub is detected by auscultation. A patient has a barrel-shaped chest characterized by Equal AP to T transverse diameter and ribs being horizontal. Alright, so the apex is 3 to 4 centimeters above the inner third of the clavicles. The base rests on the diaphragm. The lateral left is the 6th rib, mid-clavicular line. The lateral right is located at the 5th intercostal, and the posterior apex is located at C7. Normal chest, it's it's elliptical shape with an anterior posterior transverse diameter in the ratio of 1 to 2. Barrel chest is anterior posterior equals transverse diameter. Pectus excavatum, sunken sternum and adjacent cartilages. Pectus carcinatum, forward protrusion of the sternum with ribs sloping back either side. Scoliosis, the S-shaped, and kyphosis, the humpback. That's everything. Hope y'all enjoyed. See y'all later. I'm going to bed.